All right, welcome everyone. This is Breakout session 2, and I do want to ask you to please mute yourselves to prevent any interference and make sure that we can hear our speaker. If you have questions, please put those in the chat box. We will have 10 minutes at the end of the presentation to do a Q&A with David Berman. So yes, welcome to Integrating Mental Health into Chronic Disease Prevention Strategies. An opportunity for change. I'm Courtney Stewart. I lead the Indiana Joint Asthma Coalition, and I would like to introduce the speaker for today's session. You can read more about him and the detailed agenda that you received earlier today via email. David Berman, MPH, MPA, Vice President of Harm Reduction and Crisis Stabilization Programs for Mental Health America of Indiana, as well as the Director of the Indiana Suicide Prevention Network and the Depression and Bipolar Support Alliance of Indiana. So welcome, David, and I will turn it over to you.
Awesome. I hate putting bios together and then they're long. And so I like the just give the name, the title, read about it on your own. I was talking to Karen and Courtney before we started how I came in at the tail end of Antonia's presentation, and I almost thought about just scrapping this whole thing and playing like, you know, Hokey Pokey or YMCA or something, because if we're talking about mental wellness and we're talking about public health and whole body wellness, what better than to sit there and jam out to like YMCA for the next 40 minutes or so. But we're actually here to talk about the public health approach to mental health and the necessity of integrating mental health within healthcare coalitions. So let me share my screen here. All right, can everybody see this okay? Awesome. I have a whole bunch of stuff, including data, that I'm going to throw at you. We're going to fly through this. Of course, I added a bunch of slides this morning. I figured if we're talking public health and mental health, we need to have mental health data. So I'm going to fly through it. You'll have the presentation afterwards. I'm an East Coast boy, so I can talk really fast, and we are going to get this done. All right.
David, we're not seeing the presentation mode. If you want to duplicate the presentation in the display settings.
Yep, hold on a sec.
Just a note, it worked
Better
when no one was looking. There you go.
That's better. You'd think I'd never used Zoom and screen shared before. Anyway, all right, let's get going here. So I think it's important to know the why before we get into the how. So let's talk a little bit about mental health and what we're seeing. So we know that 50% of all lifetime cases of mental health disorders start by age 14, about 75% by age 24. Unfortunately, it's still about 8 to 10 years of a delay before the onset of any symptoms before most folks that access treatment get any. But unfortunately, that's only about 40% of the population that are in need of services. Median age of the onset of the symptoms that we see for anxiety disorders about 6, primarily starting with things like separation anxiety. Kids are going off to school, they don't want to go to school, they throw a fit. About 11 years old for ADHD and other behavior disorders. Part of that is chemistry. Part of that is the structure of a scholastic environment where you actually start to see the symptoms that may have been present before, but weren't as evident because of the lack of structure. And then 13 years old, mood disorders. That's pure chemistry, that is puberty. That is when we see a heck of a lot of the chemical brain changes. We start to see the transition of gray matter to white matter. And so that's when the prevalence of mood disorders really occur. So about 44 million adults in the US have a diagnosed mental illness. About 8% of our population, 17.5 million, have a serious mental illness. And those are things like bipolar disorder, depression, anxiety, psychoses. Depression, though, is the #1 cause of disability in the world, more so than any physical disease. From an economic standpoint, it's about $280 billion per year as far as cost for mental health and substance use treatment. $650 billion, though, untreated as far as the impact from crime or loss to reduce productivity, healthcare expenses, turnover. Untreated, obviously, is significantly higher cost to us in the US than actually paying for treatment. So what about the pandemic? We know toxic stress and traumatic experiences are linked to mental illness, anxiety, depression, whether it's new or whether it's something that's exacerbated, that it pre-existed. Critical event, 30 to 40% of the impacted population will likely have a new mental health disorder, specifically from the event itself. Now that 30 to 40%, that was pre-pandemic. Disasters like earthquake, hurricane, tornadoes, smaller footprint, smaller epicenter. I would venture to say that when we look back, not even 5 or 10 years from now, but we could probably say it now, 100%. I would venture to guess 100% of the population of the world has been impacted from a mental health perspective because of COVID. What does that look like? Well, everything. I mean, you see a gazillion things on here: business, education, environment, safety, government, everything. COVID has become everything. Everything has become COVID. So as recently as 2 weeks ago, CDC has been doing a household pulse survey for, I think, since last May, looking at a number of things, but in the case of mental health, specifically anxiety and depression. And the last survey that came out, which was about 2 weeks ago through the end of August, 32%, almost a third of adults in Indiana reported symptoms of anxiety and depression. So one of the other things they looked at was individuals, adults that needed counseling or therapy in the States, but did not get it over a month period. We are the 16th worst state as of 2 weeks ago, 16th worst state. So I'm going to fly through some of this data quickly. Mental Health America National does an annual State of Mental Health in America report. Basically, they look at 50 states and District of Columbia, rank them on 50 mental health and access measures. It's a good snapshot of mental health status for youth, for adults, when we look at policy and programs and various approaches to mental health. And it tracks the prevalence of mental health issues and access to care. So what are the key takeaways of that report? And I'll make that report available to you guys. We are the 6th worst state, 45th out of the 51, 6th worst state for youth that have a major depressive episode in the past year. We're the 9th worst state as far as the gap between those in need of mental health care and those that are mental health care providers. And we're the 9th highest state for adults that have seriously considered attempting suicide over the past year. That has increased 24% over the last 10 years. Increased 24% over the last 10 years of adults that have seriously considered attempting suicide in the last year. Mental Health America National also has screening data, self-screening tool that they use. Was created in 2015. It is probably the most widely used screening tool in the country, anonymous, free, totally confidential. So it's a great resource. So over the last 6 years, you can see here on the left-hand side, out of Indiana, we had 116,254 self-screenings. Between March of 20 and last month, pandemic months, 62,428, 54% of a 6-year total in 18 months. Risk categories, probably not surprising: loneliness, isolation, trauma, relationship problems, grief. The screenings are ranked from mild or non-existent symptoms to moderate, severe, or positive symptoms. And so you can see total and the last 18 months, the positive or the moderate to severe symptoms, about 75% of all screenings. Pretty consistent. Over the last 18 months, you see past treatment, 55.6% have never gotten treatment, 53.16 currently, or I'm sorry, it's not currently receiving treatment. So basically what you can see here is that the majority of people are not within the system, either having had a diagnosis, receiving treatment, anything along those lines. Top 3 screenings, 77% of all the screenings, depression, bipolar disorder, and anxiety, the 3 main precursors to suicide-related behaviors. Top 3 screenings over the last 18 months, same 3. And the last 3 months, those 3 screenings, 40% of that 6-year total in the last 18 months. When we extrapolate that moderate to severe or positive and those screenings that were taken for bipolar disorder, anxiety, and depression, and we look at an 18-month comparison, March of 2018 through August of 19, March of 20 through August of 21, 418% increase in individuals that screened for depression, bipolar disorder, anxiety, moderate to severe symptoms. Those are individuals that are at higher risk for suicide. And then finally, data-wise, I want to share Mental Health America again did a COVID report, couple of COVID reports that looked at 2 specific things: depression, severe depression, and suicide, suicide behavior, suicidal ideation. It's the largest group of data that's been collected, mental health oriented, as far as the COVID months. Basically, what they saw is that nearly 2/3 of individuals with symptoms of moderate to severe depression, 2/3 of individuals that took these screenings had moderate to severe depression, and 40% overall across the country had thoughts of suicide or self-harm more than half or nearly every day over a 2-year period. Where does Indiana fall? I'm glad you asked. So as far as depression goes, they looked at, broke it down not only by state, but also by county. And Indiana had, they looked at 2 different categories, large counties, so like Texas or California or New York, and then small to mid-sized counties, which are all of Indiana counties. We had 3 of the top 20 counties for severe depression during the COVID months: Dearborn, Ripley, and Pulaski counties. Want to guess how many counties we had when it came to suicide? 3. Switzerland, Ripley, and Dearborn, and 2 of them are the same. 3 out of the top 20 counties for both suicide thoughts and severe depression during the COVID months. Overall, as a state, where did Indiana fall? Number 2 in the country plus DC, number 2 out of 51 for depression, number 4 out of 51 for suicidal ideation. I think it's important to understand where Indiana is and what the issue is and why we need to have a more integrated approach. So obviously, our mental wellness affects all aspects of our life. This is a mind-blowing stat. The average decrease in lifespan between an individual without a mental health disorder and with one, a serious mental illness here, is 25 years. Individuals who have bipolar disorder, depression, a psychosis, on average die 25 years sooner than individuals without. Mental health disorders are associated with a large variety of physical disease factors: obesity, low physical activity, smoking. So we can then link them to things like kidney disease, lung disease, cancer. A whole myriad of physical health issues, chronic physical health issues, are directly linked to mental health. A mental illness can affect the ability for individuals to manage those chronic symptoms. Here you look at a comparison of individuals who are receiving mental health treatment versus individuals that are not receiving mental health treatment, insured and uninsured. And the individuals who indicate being in poor health, the individuals that have a higher indication of being in poor health, you can see over on the left-hand side, are those folks that are receiving behavioral health treatment. It would be interesting to see what those folks who are not receiving behavioral health treatment that need behavioral health treatment, where they land as far as reporting poor health. I can guarantee you it's going to be significantly higher than what you see over on the left-hand side. So let's talk about depression specifically, because that is the one that we're most commonly concerned about when it comes to the overlap between physical health and mental health. Rates of depression for individuals with other chronic diseases. You see here on the far left, average, those are individuals that don't have any sort of chronic disease. That's your baseline. It's about 8%. And we just start to move over to the right, cardiovascular disease, obviously things like Alzheimer's, Parkinson's, since they are neurological in nature, are going to have a mental health behavioral aspect. But things like heart disease, diabetes, cancer, you can see significantly higher than individuals that do not have chronic disease. So when mental health and physical health comorbidity exists, the untreated mental health disorder, untreated mental health can increase the cost of the treatment for chronic disease by as much as 450%. Economically, there's a major impact in chronic disease cost, treatment cost, when mental health is not treated as well. And of the 50 states, we have the 10th highest prevalence of multiple diagnosed chronic conditions among adults. So there are barriers to treatment. We know that there are barriers to treatment for mental health issues that negatively affect chronic disease. There are many symptoms that are shared: fatigue, other symptoms that can prevent recognition of coexisting due to diagnostic overshadowing. So diagnostic overshadowing can mask psychiatric complaints, particularly for development of mild to moderate mental illness. And so we need to have the ability to have more consultations with doctors, because the short consultations of the factory of healthcare, where you go in, you got 15 minutes and you're out, that's not sufficient to discuss mental or emotional health of people that have chronic health needs. So again, diagnostic overshadowing. We just talked about that. All right, wow, okay, that was the wrong notes on the wrong slide. Okay, moving on. So other barriers, stigma. Stigma is a major barrier for individuals accessing mental health care, whether they have chronic disease or not. We talk about our mental health very differently than our physical health. You break a bone, you want your cast signed, you get a bad cut, there's a story behind it, like you're making Thanksgiving dinner and you're slicing onions and you nick your thumb and it stings, you shake your hand, didn't realize that you cut the tip of your thumb off, and now there's blood spatter that's like a crime scene, that's like the entire kitchen wall. And every time you paint, every time you do like spring cleaning, you're finding more blood years and years and years later, and you can't find the tip of your thumb. So somebody got something special in their Thanksgiving meal. True story, great story. Mental health, we don't talk about it. Hey, how are you doing? That is a verbal wave. That's a verbal wave. We don't care how you're doing. And if you stop to tell us, we don't know what to do. The stigma that's associated with mental illness is a barrier for diagnosis and treatment of chronic physical conditions as well. It can directly prevent people from accessing healthcare services. Negative past experiences can prevent people from seeking healthcare in general out of fear of discrimination. Plus, stigma can lead to misdiagnosis of physical ailments. And again, that would be the diagnostic overshadowing. It's the responsibility of healthcare professionals to treat individuals holistically, but there's always been a debate. What do we treat first, the physical or the mental health? Well, why not treat them simultaneously? Why not do integrative care? So the public mental health, what is that? Well, that's a term that's been coined to underline the need to emphasize that neglected element of mental health in public health practice. It spans promotion of well-being to prevention of future issues, effective treatment, care, and then ultimately an expectation recovery built on the same principles of public health in general. So what are the principles behind a public mental health approach? Well, interventions which focus on the positive, promoting mental well-being rather than focusing on the disease. Social, economic, cultural, and environmental determinants of mental health. We need to do a better job within the mental health world, and we're starting to, especially here in Indiana, on focusing more on SDOH and quality of life factors rather than just disease itself. Universalism, addressing that population mental well-being and looking at providing additional support for those high-risk groups. Making sure there's individual engagement and community engagement. Making sure that we have a focus on early intervention, on making sure that there are protective factors in for younger children, because we know that the trauma that kids experience lasts a lifetime. When you look at ACEs and the prevalence of ACEs, and you start getting up in numbers 6, 7, 8, this is lifetime significantly escalated risk for suicide, even as adults. So we need to make sure we focus on our youth. And then a multidisciplinary and intersectoral approach has to be adopted, because there is no one area that has all the answers, especially when we're looking at the interconnectedness for physical disease and mental health. And then you have to do self-care. So as part of that universal approach, if you are not focused on your own mental well-being and the mental well-being of your coworkers, your peers, then it defeats the purpose. So again, if we're not turning on the chicken dance or the hokey pokey and we're watching presentations all the time, that does a disservice to our own mental well-being. And we need to make sure we're focused on that as well. So what does it look like when we're talking about prevention, when we're talking about treatment, when we're talking about risk factors, physical health, and mental health? They're very similar. So physical health, what do we want to do to promote physical health? Nutrition, exercise, rest, good genes. That is a protective factor. Not a lot we can do about that, but that's a protective factor. Mental health, we want to make sure we understand and can regulate our emotions. We manage our stress. We are engaged in positive social relationships. The list is very long. We could talk about this all day. And these are just some of the things that we need to do to make sure that we maintain good health, mental or physical. How do we reduce risks? Well, on the physical side, things like hand washing, or in the case of COVID, masking up, universal precautions, immunizations. Mental health, we want to eliminate trauma. We want to reduce chronic stress. We want to do more informed parenting, teaching parents how to be more supportive, better parents, positive life skills, promoting positive relationships. Recognizing signs when there is an illness, temperature, cough, fever, pain, all the things you would typically think of. How about on the mental health side? Extreme negative emotions, noticeable stress, suicide-related behaviors, substance misuse. How do we address it on the physical side? Early detection, screening, stop that bleeding and pain, push the broken bone back under the skin, and save the life first. You know what? It's the same on the mental health side. Early detection, stopping the pain, emotional pain, and keeping individuals safe for now, for themselves and for their communities. So the 6 dimensions of wellness, I think, are a vital part of looking at kind of that whole mental health perspective. It's all about the occupational, enrichment of life through work, interconnectedness to living and playing, physical activity, eating, strength, vitality, personal responsibility, and self-care. We have the social. How do people contribute to their environment? How do you build better living spaces, social networks? Intellectual, making sure we have creative and stimulating mental activities. Spiritual, our belief systems, our values. And then emotional, our self-esteem, self-control, determination as a sense of direction. So typical local public health system, you can see here, obviously you have your health department in the middle. These are your coalitions. This is a health coalition. It is integrated and involves every aspect of the community. We have to take that approach. So how can health coalitions support collaborative integrated care? You're the experts on a public health framework. make sure that you're utilizing that knowledge. Cultural competency. We do a very bad job within the mental health world of ensuring that there is cultural competency, that we have a DEI lens when it comes to mental health. Data. We do a really lousy job here in Indiana with data sharing and data collection when it comes to mental health. And this includes looking at the non-traditional data that we talked about a little bit, SDOH and quality of life data. Be a convener, continue to be a convener, and take advantage of volunteers. There are a tremendous number of volunteers that have just come out of the woodwork over the last 18 months on the mental health side that want to do whatever they can to ensure that mental wellness is a priority in their community. So we want to promote collaboration, connect with mental health organizations, identify strengths of the current coalition members. When you look at integrated healthcare and lean on those folks, figure out who's going to take the lead, whether it's within the coalitions, whether it's the mental health organizations. Figure out who's already doing the work. Why reinvent the wheel? There's gap analyses that are going on across the state looking at different things, mental health related. There's a lot that we don't know. And there's also a lot that we don't even know that we don't know. We want to make sure that we come up with an effective plan for outreach and collaboration. And again, engage non-traditional providers, not just non-traditional healthcare providers, but non-traditional mental health folks as well. We want to educate about what integrated care looks like in communities, but also with consumers, individuals that have lived experience. It needs to be person-centric. We do a terrible job engaging individuals that are in crisis, individuals that are engaging or that are within the mental health system and determining what they actually need. And we know that there are barriers for individuals accessing services based on the things that we're doing wrong and the things that we're not doing at all. And we need to get better feedback from those that are either already part of the system, need to be part of the system, have experienced mental health crises, but has not accessed services. We need to get that lived experience. We need to make sure that we support an integrated care workforce development. What additional trainings need to be in place for both those individuals that are doing physical health work, as well as those that are doing mental health work? How do we share that experience? We have a workforce shortage. We know that there's a workforce shortage. And so we need to make sure that whatever training is done is appropriate and covers all the bases as we're looking to do more integration. We need to make sure that we're looking at alternative ways to bridge the gap when we're talking about workforce, considering there's not enough of a workforce out there. Looking at subacute services instead of always acute, because we take people so often that need subacute services and put them in an acute service box, meaning hospitalization or traditional therapeutic treatment. So we need to look at alternative ways. That's a good way to shore up that shortage in the workforce. We need to support integrated care service. Work with MCOs. They are interested in providing mental health services to their members. Yes, part of it is financial, the whole concept of wellness and making sure that you do the preventative work on the front end, which decreases the treatment cost. Yes, somewhat it's economic, but they're also starting to do it because it's the right thing to do. I've had several meetings over the last couple of months with MCOs that are literally willing to do anything to ensure the mental wellness of their members. Sponsor work with organizations that do support groups, Mental Health America, NAMI, Depression and Bipolar Support Alliance of Indiana, making sure that those individuals that are attending support groups for mental health understand the whole integrated side on the physical health side. That's where you guys are the experts. Get involved in in-service education efforts, looking at service delivery issues where further education is needed, and get out of the box in that delivery. There's some things that have come out of COVID that are positive. There are things that have really looked like something that we should have done a long time ago that we just sort of went with now because we were forced to. Necessity is the mother of invention. And there's so many things that we do at a necessity that we really should have been doing all along. So out of the box delivery of programs is crucial right now. I would be remiss when I talk about mental health if I didn't at least take 30 seconds to talk about resources that are out there, whether they are for individuals that you work with, family, friends, yourselves. There are a ton of mental health resources. You see just several of them out here. National Suicide Prevention Lifeline, both in English and Spanish, the Crisis Text Line, 741-741. There are EAP programs, and there are traditional behavioral health care, community mental health centers and private practitioners. Also, since I'm providing oversight to it, I'll throw it out there. The Be Well Crisis Helpline under 211. It is an amazing program, 24/7, confidential, totally anonymous. We have 36 crisis counselors that have an amazing breadth of experience and training located across the state to provide real-time crisis counseling, no matter what the issue is. You just want somebody to talk to, all the way up to you have real thoughts of suicide. All right, that was very, very fast. I think I went 2 minutes over. I threw a ton of stuff at you. This is more like a, I don't know, 50-minute presentation. You'll get a copy of this, but if you have questions or comments or want additional information, there is my contact. Do not hesitate to call. It's my cell number there. I should probably not be giving my cell phone out. I did a radio show for Radio 1 last week. Made the mistake of giving my cell phone out. Will not make that mistake again, but text me, call me, email me if you have any questions on any of this stuff.
Thank you, David. That was an amazing amount of information, and it's so important for what we're dealing with right now, and especially those stats about Indiana. So thank you for that. And yes, this will be available to everyone, the presentation and a recording as well. I do have a couple of questions in the chat for you, David. And the first one is, when is the typical onset of OCD?
So OCD is an anxiety disorder. OCD is usually later in life, so late teens to early 20s. But what we see with anxiety is different types of anxiety, or anxiety can escalate from one type of anxiety to another. So typically you're always going to start out with that separation anxiety or something as a young child, and that OCD becomes is a little bit later. So I would say, 17, 18 and older.
Okay, thank you. And then there's another question. So did the statistics apply to anyone with a mental health disorder or just for those who are untreated?
The statistics, which statistics of the
Right.
400 I threw at you?
Sorry, I typed that when you were going over a particular slide about possibly having your lifespan reduced by 25 years or being at more of a risk of developing chronic diseases and stuff. Was that for anyone with a mental health disorder, whether or not they're seeking treatment for it, or just for
Yes.
those that maybe go undiagnosed or untreated?
No, everyone.
Okay, thank you.
And then I've got another question. Do you have recommendations of specific mental health education curricula that non-clinical staff could provide to community members?
So there is, there's a variety of stuff. Everything from QPR, which is basically a suicide prevention 101, very, very basic, focused on suicide, recognizing the warning signs, asking the question, connecting someone to resources, to mental health first aid, which is a QPR is about a 2-hour training. Mental health first aid is a full day 8-hour training. It is a mental health substance use 101 that looks at kind of the whole breadth of everything under the behavioral health umbrella. There's psychological first aid, which is more almost more of a public health approach. Psychological first aid is used by the Red Cross. I provided oversight for the last year and a half for the state's FEMA-funded crisis counseling program in response to COVID. And psychological first aid is the training that we traditionally use across the board for anything related to an event. Again, earthquake, tornado, flood, COVID, when we are talking about some sort of mental health response. So yeah, I mean, there's probably half a dozen, 8 more. I am a certified trainer in some of them. Mental health first aid, psychological first aid, QPR, the ones that I mentioned. There's others. I'm happy to talk about with anyone that's interested doing a training or connecting you to folks who do a training, depending on where you're located, or suggesting other ones. So again, just reach out and I'm happy to share with you.
And it looks like Tanya put the extension, mental health first aid, the link to that in the chat, if anyone is interested in finding out about training for mental health first aid through extension. We have a couple of minutes before we head back to our main Zoom link, if there are additional questions.
I would have slowed down if I knew we were only going to have
you've done
a handful of questions.
It's perfect. All right, I have a question, David. As a coalition lead, and you kind of addressed this in your presentation, we're dealing with people that have various chronic disease in the state. What are some good ways that we can incorporate addressing mental health in our work as coalition leads?
So I think, honestly, I think what you guys are doing already, so I'm trying to think how to phrase this. The SDOH approach to mental health is brand new on the mental health side. I don't know why it's brand new. This should have been kind of the focus all along. Use of peers is brand new in the mental health world. If you look on the substance use side, I mean, AA programs, that is pure lived experience utilizing peers for treatment. So I don't know why we're slower to adopt certain alternative approaches, but we just are. But what you're already doing on the SDOH side applies to mental wellness. Everything that you would use to promote prevention, upstream prevention from a physical disease side is going to apply to mental wellness. I mean, it is. Healthy eating, that's going to prevent heart disease. That's going to prevent diabetes. That's going to prevent a myriad of physical diseases. That is a protective factor when it comes to trauma, when it comes to mental wellness. Exercise, same thing, physical health, mental health. And so I think it's ensuring that individuals understand that concept that everything that we do affects our entire body. Everything we put in our body, every step we take, the relationships we have, the activities that we do affect our mental health every bit as much as our physical health. And really taking exactly what it is that you're already doing and ensuring that that message is conveyed, that it's linked. They are synonymous. Health is health is health is the best place to start.
Thank you for solidifying those connections. At this time, there are a couple more questions, but we want to get back to the main Zoom. I put the link in there so that we can hear the closing remarks from Dr. Sarah Weehee. Again, you will have access to David's presentation and the recording. And so those additional questions can be, I would suggest emailing David with those if they were not addressed. I knew there would be a lot of questions about this. Please join us in the main Zoom. And thank you so much, David. Really
My
interesting.
pleasure.
Much appreciated.
My pleasure. Thank you.
You're welcome.